Good morning. My name is Mahmut. Adrian has many studies and books on this topic. She has so many works on this, and I believe that we have to benefit from her experience and information mostly. I'm just going to talk about why drugs should not be used during pregnancy and why we prefer ECT over drugs. And then I'll pass the floor to Adrian. FDA, you know, has removed the categories in pregnancy, but I mentioned these categories in my slide since we all know it, but I'm not going to read them one by one. The most important thing to do for a medical doctor is not to do any harm. First, we do no harm, and then we try to treat the patients. We know that 3 to 4% of newborns have congenital abnormalities. 10% of these abnormalities are induced by environmental conditions, and less than 1% is induced by drug use or exposure to chemical substances or physical factors, and most of it is unknown. The embryonic period during which the substance is exposed to, its time of action, dose, the threshold value, pharmacokinetics, the genotype of both the baby and the mother, and maternal diseases, obesity, all these factors have an impact on abnormalities. When we look at the side effects of psychotropes in pregnancy, we see that there are controversial outcomes in many studies. There are various studies, but we can say that they might lead to intrauterine death, teratogenicity, and organ malformations, and it might also lead to withdrawal syndrome and toxicity after delivery. The effects of antipsychotics, antidepressants were discussed in detail yesterday during the course, therefore I'm not going to talk about them. Actually, treatment in pregnancy is like a two-edged sword. I mean, even if we left schizophrenia or bipolar disorder untreated, both the baby and the mother is affected negatively. And when we prescribe drugs for these two disorders, they also do harm to both the baby and the mother. Let's say the baby is born. What is going to happen with the behavior of the baby? What are the behavioral syndromes? What is the IQ level of these babies, or some behavioral disorders caused by these drugs? There are studies in that respect as well, but this also is a question mark, and benzodiazepines, the mood stabilizers, we have the same concerns for these drugs as well. When we look at the factors that affect the transition of the drug into the mother's milk, is like the pH, diffusion pace, and also the half-life of the drug, and time to the highest level of the drug in the mother's plasma, the milk plasma ratio, and oral bioavailability. These all have effects on the drug penetrating into the mother's milk. During pregnancy, we prefer ECT, not during lactation, but during pregnancy. If the patient has an anxiety disorder, of course we do not perform ECT. We perform it according to its indication, but let's say in cases of catatonia, retardation, depression, bipolar disorder, we prefer ECT over drugs. And as far as we know, it is safe in all 3 trimesters, and it has a very speedy action, and mortality is low. Of course, we have to pay attention to the co-medication, and especially drugs that we give for anesthesia purposes. And these drugs that we administer during ECT are all drugs with a very short action. Let's say the patient developed echinavirus, but let's say there was a familial tendency, they have it in their family, then it's not directly related with drug use. This is another study from Antep. In this study, one of the patients, in only one of the patients, we have observed early delivery after ECT, but other than that, there was no problem, and there was no relationship between the previous case I mentioned and ECT, not drug use. I'm sorry. Why shouldn't we use any drugs during perinatal term? Since we cannot try them on humans, we don't have clear data, because we first do in vivo studies in a controlled environment, in a clinical phase study, and we have phase 1, 2, 3 studies in our clinic, and we identify a group of patients without diabetes, with normal blood levels, and without any other problems, and the patients are not resistant to treatment. So it's kind of an experimental sample. Their liver enzymes, electrolytes are checked continuously. So this is actually a pure population. However, this is not the case in real life. We know that during pregnancy, one pregnant woman, in addition, except for the psychological drugs, is taking 6 or 7 drugs. And antidepressants are commonly used during pregnancy, and they are metabolized by liver. And as you know, P450 enzymes are used for that. And 1A2 to C9, 2C19, 2D6, and 3A4 are responsible of psychotrops metabolism. And these enzymes have so many genetic variations, and this applies to both the mother and the baby. I mean, they might have different genetic variations and might metabolize the drug differently. The pregnancy itself has an effect on these enzymes as well. For instance, CYP2D6, 3A4 to C9 activity is increased, 1A2 and C19 activity is reduced. The blood volume goes up, cardiac output is increased, and of course this changes the efficient dose of the antidepressant. And also the passage of that effect to the baby. And all drugs have R and S enantiomers. However, they also have chirality. I mean, like mirrors. They are mirror images of the same molecule, but they do not overlap. Let's say that this active enantiomer binds the receptor. Inactive cannot do that. And if we perform a rotation, the C part, if active is in charge of sedation, and if the C part is on the opposite side, then the drug has no longer a sedation effect. You know, thalidomide, this disaster, it has R and S forms. R form has no effect. What actually stirred everything up in the world is the S form, and these are mirror images of each other, and this happens in the body. I mean, I cannot just take and give the R form and nothing happens, but in some bodies this R form can be converted into S form. So 50% of drugs in production are all like this. There is such an interaction. They are mirror images. They both have the R and S form. Citalopram, for instance. Escitalopram was the S enantiomer of this molecule, and its binding is 30 times more than the R enantiomer, and has less adverse effects. However, when we look at racemic fluoxetine, the R enantiomer of fluoxetine was stopped in phase 2 trials because it extended QTC. So QTC was extended in phase 2 for escitalopram. This R enantiomer increased the sales of this drug, but the other one could not be introduced into the market, and partially the human body is capable of such conversion. One is doing good, the other one is doing bad, as you see. So in conclusion, there are so many confusing factors and controversial data as regards use of drugs. And there is no racemic form in ECT. There is no mirror image in ECT. There is no interaction with other drugs, not much. Therefore, I believe that in major psychiatric diseases, ECT should be preferred over drugs for indications, when there is an indication for a certain disease. And in other cases, we have to base our decisions on profit-loss ratio. Thank you.